Welcome to this edition of AFMC
I'll tell you how I got better. I'm
Glad to be here.
A mission to
Delivery of
improve.
I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Anthony Davis. He was in private practice for over 12 years and is a board-certified neurologist at UAMS, specializing in dementia and headaches. And Dr. Davis, thanks for being here today.
Absolutely. Thank you for having me.
So we're talking about headaches today, treatments, types. Headaches are tough to treat. Why?
They can be very tough because there's several different types of headaches which change up how you would approach both treatment and prevention if needed. And then also it's such a large determinant of disability in this country. It's very common. It stops people in often the prime of their life and eliminates their ability to work and to perform normally. So it is a great problem that we face, and we try to figure out a right treatment for each patient.
And you mentioned there are different types. What do you mean by that?
So most commonly people talk about migraine, and I hear people use the word migraine as if it's just means a bad headache. But headaches have different, what we call semiologies, meaning different symptoms that go with it. And of course, migraine is very common, and it has some classic features, such as it's usually unilateral or one-sided. Often can be accompanied by some symptoms initially that we call an aura. It can be a throbbing pain, as well as accompanied by symptoms of sensitivity to light, sensitivity to sound, and nausea and vomiting. And so that's kind of the classic migraine. But then also another very common type is tension headache, which generally is more on both sides. It can often be band-like, or as if you're wearing a hat that's too tight. And then there are some other less frequent headaches that can be very severe, such as the autonomic trigeminal cephalgias, which include cluster headache. But these headaches are mediated by the trigeminal nerve and can have differing lengths, often having shorter duration but much more frequency of headaches. And those have some special symptoms along with migraine symptoms. They can also get what we call autonomic symptoms, which would be tearing of the eye, runny nose, redness of the eye or injection. And those can have a specific set of treatments as well.
So are there new headache drugs on the market, or is it kind of a same old treatment that we've had for years? What are you seeing?
So you're absolutely right. Definitely that we've had the same old treatment for a long time. And I described to my patients that we try to bake a cake that pleases every palate, but we only have so many ingredients, because classically we used anti-seizure, anti-blood pressure, and antidepressant type medications were the core medicines we used for prevention of headaches. And then the triptans came out, 20 to 30 years ago, and were great for acute treatment of headaches, meaning headaches that we need to treat right now. But the most recent change has been a new class of medications that all look towards a protein called calcitonin gene-related peptide. And this has been discovered in spinal fluid of patients with migraine headaches in particular. And it tended to go up when the headache, and then it would come down as the headache resolved. And so that's opened up a new mechanism of action that's brought these new drugs out as a possibility for patients.
So is it personal, different for every person? There's not like a cookie cutter solution or type of headache for everyone?
Certainly not. And so the first thing that I tend to do is just take a headache history, anything from some of the symptoms that I mentioned, but also how long the headaches last, how frequent they occur in a month or in a week, what age the patient started having headaches, if there are any precipitating factors that can bring a headache on. And usually if you start to get that information from patients, you can get a better guess of the type of headache or what the actual cause is, whether it be any of these types that I've mentioned or something even more odd. And so then you can try to guess of whether you need to go with just an abortive therapy. For example, if you have a headache patient that only gets one per month, then you can probably get by with just treating that single headache. But if you have a patient that has 2, 3, or daily headaches per week, multiple headaches per week, then in that case, generally we'll go for a more of a prophylactic measure where we take something on a regular schedule, regardless of whether they have a headache or not, in a goal of removing or reducing the number of headaches over the month.
And there are injectables and infusions, and those are different than the other abortive meds.
Yeah, so with the CGRP type drugs, there's two main types, and there's what they call the GPANTs, and that's because they each have GEPANT in their name. And these are oral medications, and most of them came out as an abortive. And the brand names of these that people will be familiar with is Emgality. Scratch that. Ubrelvy and Nurtec are the two most common GPANTs that are used as a abortive measure. And then there was another one called Qulipta that came out and was FDA approved as a preventative that you actually take every day. And then after it was introduced, Nurtec also was FDA approved for every other day dosing as a prophylactic as well. So the other class of medications are monoclonal antibodies. So they end in MAB. And those drugs are infusions or injections that you can do at home. The three classic that we use on a monthly basis are subcutaneous injections of Aimovig, Ajovy, and Emgality. And those block the CGRP on more of a long-term basis by using a monoclonal antibody method. And then there is another infusion called Vyepti that's done almost more like a chemotherapy drug, but it's still in the same family as the home injectables. And those are used for prophylaxis.
So there's been quite a bit of improvement, would you say, or change within these treatments? I mean, it sounds like there's a lot more available for patients to try than there was, say, 10 years ago.
Definitely so. A lot of my patients have had few side effects with these medications. Of course, there are side effects with any drug, but generally they're fairly well tolerated. And one of the biggest problems that I run into is sometimes they just don't work. And you have to think that maybe you've got the headache type incorrect, that maybe it's a different mechanism of action of what's causing the headache, or potentially you need to change to a different agent. Another big problem with these medications is, of course, insurance payment, because they can be $700 to $1,000 per month. And there's a lot of different copay problems. And from a practice standpoint, often I didn't get to pick the drug based on what I thought was going to be the best drug for that patient. I had to look at their insurance and see which one was preferred, because it is different from carrier to carrier.
That makes things in treatment really hard for the physician, I'm sure.
It does. And I don't think that there's a doctor alive that went into medicine to handle those kind of issues. We want to be able to get the medications that our patients need. But at least personally within my clinic, we had a notepad that we had shared amongst all of our computers where my medical assistants would leave little breadcrumbs of, okay, if the patient has Blue Cross Blue Shield and it starts with this 3-letter number on their policy, then they're going to prefer to have Aimovig before Ajovy, for example, or something like that. And so unfortunately that brought insurance into the clinic space.
So interesting. And so let's talk about, oftentimes the PCP is at the forefront of patient care for headaches. That may be all that they see. Before a patient is referred to you, what needs to be done before they see a neurologist for headaches?
Well, of course, we're always grateful for our interactions with our PCPs, because they are the tip of the spear for these patients. And I will say that as a neurologist, they don't only have to send me the hard ones. I'm certainly happy to get the easy ones as well. But often the easy ones hopefully will respond to a single medication and have a good reduction of their headaches to ultimately not just reduce the headache frequency or the headache severity, but decrease the amount of disability, the number of times that work is missed or canceled plans and things like that. And so generally I would recommend that they talk through the headache. They try to get an idea if the symptoms point to a certain headache type, because that may guide them in which medicine to try. But thankfully, at least between tension headache and migraine headache, cluster headache, some of these, there is some significant overlap between which medications that we use. And so often they can try a single agent and see how the patient works with it. But if they have adverse effects or the patient doesn't respond, then certainly referral to neurology is appropriate.
Well, Dr. Davis, I appreciate you talking about this important information today, and thank you for all you do for Arkansans treating headaches and dementia. Thank you for being here.
Thank you so much for having me. This is a great topic, and I hope this helps.
Well, that's it for this episode of AFMC TV. Thanks for watching. Have a great day.